Hey everybody, it's Dr. Linda of the VBF. Give me a second. I'm checking to see that we're live from Milan, Italy. Let me just make sure I see us on here. I know we're live on there, but I've got to make sure we're live on here because this is where I get the questions that you submit. So I should see us popping up on here, and I don't know why. Let us know in the comments section. I see a lot of you are in there, so text in the comment section and let us know that you see us. I know we're like 1 minute early, but okay. It's Christine. Let me get that off. I'm still not seeing it on my phone. Oh, it says we're live. Oops, hold on. So it's saying it now, so I should see us. Where are we? Should be on here. I'm not seeing any comments, so please just let us know you see us, okay? It says we're live. It says here we're live, but I don't see us on here. It's not on. Oh, please tell me I'm not. No, I am on the VBF page. I'm not on my personal page. Let me just check. I hope I'm not on my personal page. That happened to me the last time, and I had to log off. So sorry about technical difficulties, but Meta makes it terrible. So nope.
There are comments there.
Okay, great. Hi. Let me get back over to my VBF page, so it should now populate, because it is saying we're live, so I should see us on here. And I don't know why I'm not seeing us. But you guys are seeing us, and I'm not going to be able to see the questions. Can you pull up our page on your phone?
Of course.
Because then it might be showing up on yours and just not on mine. I've been having some problems. So if you pull up the VBF Facebook page. Yep, I see everybody. Hello, Kiana. Hello, Dvorka. Hello, Alexander. I'm just trying. I'm having a little problem pulling it up. It says it's live, but it's not showing us. It's showing another video. Okay, it's live. Where are? Oh, there we are. I got it. All right. Let me turn this off. So, welcome everybody to the June 2025 VBF Facebook Live with everybody's favorite, Dr. Giacomo Colletti from Italy. Thank you
Hi,
for
everyone.
doing this. And you can tell everybody what we just finished doing.
Yeah, we finished a super clinic, the well-known super clinic, which is held at least once in the US, more often than that, I suppose now, and once in Europe, and this year is Italy. And it's always an honor and a pleasure being part of this. We've seen many patients. We have done many procedures. Unfortunately, we have changed some of the diagnosis. That's always unfortunate in the sense that it's not pleasant to tell a parent or a person you have had a wrong diagnosis for many years and your correct diagnosis is this one. Sometimes it's better, but other times it's a worse diagnosis with all that goes along with this. So
Right, but what do we always say? You have to start with an accurate diagnosis in order to have an appropriate treatment plan. As we saw today, we had a child who'd been on a drug for a year that was inappropriate, then had a procedure which could make things worse.
yeah,
But now we know that what she has, we know what the treatment options are, and this is why VBF has you come with the ultrasound, and every single clinic, don't we find a case like this? And it just shows
absolutely,
how
always
critical
yeah.
it is. So I see a lot of you are jumping on. Let us know where you're from. Don't forget, you have to tell me the country that you're from. And I know a lot of you normally come. Hello from Georgia. Okay, hello, Alexander. Hello, Christina, Samantha, Dvorka, Catherine, Neelam, Bernard. Oh, Bernie's on. Bernie Cohen is saying hi.
Hi.
Buddy is saying hi to everybody.
Hi, buddy.
Hi, buddy. So
we miss you here, buddy.
we are live for 1 hour. You have the greatest opportunity to ask questions directly to Dr. Colletti, and I have the first one. And so please ask the questions while you have them now, because he's a moving target. Once he's done here, I won't see him for a while. So Nabil says, has there been any new treatment for port wine stains for removing the color?
Well, what the literature says is that PDL laser, and specifically the 595 with dynamic cooling device, is still the gold standard. So there have been some proposals for new wavelengths. Someone is using the 532, and it seems that some patients may benefit from that, but to be honest with you all, the PDL is still the gold standard, and some have tried electrosclerotherapy on capillary malformations as well, and it does work very well for hypertrophic capillary malformation, but it doesn't do much for the color, unfortunately.
But we could talk about the Pro, the newest laser, bigger spot size, the bigger spot size. So before it was this big, now it's this big. Each zap, it goes deeper and it's quicker. So Dr. Geronimus says it's 40% better, almost half, double, of faster, bigger, deeper. Patients are saying it's the least painful of all lasers. There's only 4 places right now in the US with it, but Candela has announced that they're manufacturing more right now. Some will be delivered in June, and good news, the Pro will be in Europe before the end of the year. So at least you know that, yes, that's right, to get this here. So please ask your questions. Hello, Northern Ireland. Hello, Bologna, Italy. Francesca Galiberti. Hello, Diane. Hello. That sounds awesome. What's it called? Okay, I just mentioned it. It's called the VBeam Pro, and it's not in Europe yet. Only in, and we have a free clinic coming up in October in New York, and Dr. Colletti will be at it. And we are using the Pro. So if you come to the clinic at birthmark.org, sign up. You get free lodging for 1 night, free ultrasound, free dental, free laser, free psychotherapy. If you have glaucoma, you'll have a free glaucoma check. Did I say dental, orthodontry, psychotherapy? We've got it all now.
Absolutely.
Do you know anybody that does what we do?
No way.
Nobody. And the talks at NYU, there's going to be 14 doctors giving top talks.
The most updated, with the most updated data.
Exactly.
Something not to miss if you have the chance to come.
Oh yeah, so Dr. Cohen is saying with the port wine stains now, and this is especially our protocol in the US, is to start right out of the birth, right? And a lot of people are starting this in Europe, but we're really spearheading this. I call it done by one, but it's not to criticize anyone who's not been able to get it started before then, but it's just a goal. If we can start in infancy and do it every 2 weeks or 1 week like Dr. Geronimus does, the baby can reach maximum clearance before age 1. Then they only need maintenance.
At least we can try.
We can try.
In any case, again, all the papers that have been published agree on the fact that the sooner you start, the better the result. Also, if you start very early on, the baby will not need any sedation or anesthesia, so you can have the treatment very frequent, whereas, again, the data says that if your baby receives more than 3 sedations or anesthesias before the age of 3, there's a definite risk, although low, but it's still there, risk of neurodevelopmental delay.
Important. So Alexander says, we are Dr. Colletti's patients. Now it's the first time we will be doing procedure after 6-month break. This is Alexander Nemsadze, doing procedure after 6-month break with GA in Turkey. We also have a doctor there. The kid is 2 years, 2 months. Can you please share what is the most frequently used medicine that is used for general anesthesia to treat 1/2 of the face? I soon have consultation with anesthesiologist. That's why I'm asking.
That's up to your anesthesiologist. There's many drugs that can be used. Some of them will use benzos, some others gases, other prefer ketamine. It's
Short-acting fentanyl, I think that's
that's
short-acting
that's
fentanyl.
true as well.
Mm.
So every anesthesiologist has his or her preferred technique, so you should ask them.
Daniel has a great question. He says, "Hi, I'm from the UK, Daniel Hunt. I have a port wine stain on my cheek. I'm now 40 years old and noticed my cheek has started looking swollen over the last year or two. Do you think this is my port wine stain thickening? I'm seeing my vascular consultant in a couple of weeks."
Absolutely. We know that especially untreated port wine stains will sooner or later show signs of skin thickening. If you leave it untreated, there's also cobblestoning, pyogenic granulomas, darkening of the stain. So yes, at the same time you may be experiencing hypertrophy, meaning that all the tissues underneath the skin stain grow more than they are supposed to, soft tissues and bone as well, and that's something that if present needs to be addressed surgically.
And what about the possibility that it could be bone overgrowing underneath that's pushing the cheek out? Not just soft tissue, but bone as well, right?
I think I said that.
Oh, okay. I didn't hear about the bone part, sorry. Okay, so he said Nabil said he started laser at 22. I'm now 25. I wish I had done it earlier. I heard it gets darker as you get older, which is my case, which is why we try to push. Lisa says, I'm in the UK, failed resection of venous malformation around the spine, which caused a spinal CSF leak. How is the best to get advice treatment for complex situation? Cannot get help with CSF leak because of extensive VM around leak site at T7. I cannot travel and left with no help. Any advice? What help I could get as I feel stuck in the UK? I currently have no consultant, previous surgery negligent, so left in this situation with no help.
Well, paraspinal venous malformations are a hot topic actually. We used to say don't touch them unless they are very severely symptomatic. Now we tend to change this and start treating them. The best way, in my opinion, you have a step ladder protocol consisting in first just simple injection of bleomycin plus albumin. The second is relying on a more aggressive sclerosant, but I don't like that. And the third one is embolizing the venous malformation and doing a decompression surgery on the spine. That being said, if you already have CSF leak, then probably you're going to need that venous malformation embolization, and right after that surgery to correct that, close that leak. Yeah, that's what I would do.
What about Great Ormond Street Hospital? I mean, I don't know any other, because she needs a comprehensive team, like a real vascular anomalies team, right? Or
well, she needs someone, possibly a neuroradiologist, interventional radiologist, and a neurosurgeon. They have to work together because the neurointerventional radiologist will do the embolization, and right after that the neurosurgeon will go in surgically and address your issue.
Sandra says, my daughter has a lymphovenous malformation in her oral cavity and submandibular glands. What treatment would you suggest for her? She's currently just being monitored. She's 2.5. She has only had one substantial flare-up where she was 6 months old that resulted in a feeding tube for 5 months. Her tongue was very swollen. She was unable to drink or eat. Since her first birthday, no flare-ups. Is there anything we should be doing to prevent flare-ups or treat the malformation?
There's no way you can prevent flare-ups. So provided the diagnosis is appropriate, and there's no reason not to think it is, lymphovenous malformations are prone to infection because they drain from tissues, so every viral or bacterial infection will cause a flare. That being said, I very much need to see some imaging, meaning preferably MRI, so I can tell you what I would do. There's definitely many options to help you with that condition, but I need to see the MRI.
Okay. And Kiana, our social media director, will post Dr. Colletti's email, so you can email him that information. Nabil wants to know, which I didn't say, he said, why does there need to be a 2 to 3 month cool down after each laser treatment, or does it need to be?
No. We usually say that you can have next treatment as soon as the purpura fades away, which is usually 3 to 4 weeks. After the purpura has faded, you can have the next treatment.
And a lot of people will say, then how come you keep talking about babies going weekly, but Dr. G says they don't have purpura, so he can continue treating because they're new babies.
That's different also.
Yeah, different. It is different. Christina Huff says, my daughter has a facial AVM off her carotid artery located in her left mandible. She has had 18 embolizations and it keeps growing back. Whoa, we just had this talk. Do you feel the Colletti technique, which I call, right, would be better treatment with an AVM in the mandible?
So, for unknown reasons, I tend to see patients in groups with the same disease. And just last year, I have been treating 5 patients with mandible AVM, intraosseous, yes. And I have developed a surgical technique where I am able to remove the whole malformation from inside the bone and then take care of the soft tissues with the Colletti technique. So I can definitely help.
Well, this is
I can promise that.
And again, there's the link to Dr. Colletti, and if you could just post his email in there, Kiana, it's giacomo.colletti@gmail.com. So Dvorka said, we came last year to New York. My daughter has AVM and would like to do surgery with you. Where do we go for P10 genetic testing in Maryland, and how and why is it important to do that for an AVM? What is the price of those the treatments, and is there any insurance that you are accepting? How do we send you the MRI? It's a lot.
Send me an email at the email address that you'll find here, and we'll discuss everything in detail.
Okay. Yeah, that's better. Okay, yes, alrighty. And again, it's I know there's a link, but his email, if you could put that in, Kiana, is giacomo.colletti@gmail.com. There we go. Thank you very much. Thank you, Kiana. Because then they can just cut and paste it and write you. And by all means, anyone who reaches out to him, keep it short, keep it fact-based, include any records that you have with it, any ultrasound reports or any documents that you have, and then at least
that will help greatly.
And photos, especially birth and now.
Imaging,
and any imaging. But it's important when you write to keep his ability to be able to handle all these by putting as much in as possible, so he can make an assessment rather than going back and forth and asking you for more information, and then it gets lost in like 30 other patients. So just keep it all in one thing. Okay, hi Lorenzo, and hi Diane. Not sure where you're all from. Hi Jolene, Vanja, hello. Brittany, hello. I'm making sure I haven't missed any questions. But you also said, and I just want to say this until the next question comes up, that at the ISFA meeting, you saw a possible new treatment for lymphatic malformations or a new procedure. Was it that you saw?
That was just for central conducting lymphatic anomalies, a very small niche and specific, yes, niche, which is utterly rare. So it's not a normal lymphatic malformation.
But the gold standard for lymphatic malformations, is it still bleomycin or?
It depends. It depends on the type of lymphatic malformation. It depends on the site where the lymphatic malformation is. It depends on how big or not it is. So you may have to rely on sclerotherapy, bleomycin, electrosclerotherapy, surgery, or a combination. So you cannot say the treatment indicated for a lymphatic malformation is this one. You need to say the treatment indicated for that very lymphatic malformation is this one or that one.
And how do you feel about the sirolimus as just an oral medication for these lesions?
So I have published a paper about it, and it would seem that sirolimus is effective. Not always. It's effective in 70-ish percent of the population. We should try to understand what effective means. So if you have a venous malformation, say, and you have frequent pain or clotting and stuff like that, then sirolimus is definitely able to reduce the pain, the frequencies of clotting, intravenous clotting, and all that. But if we're talking reduction in size, that does happen. How frequent? I'm not sure.
And what is the first line of treatment for an AVM, or does it again depend on how involved it is in its location?
So you remember I have published a staging system several years ago, and a refined version of the staging system is about to come out at the Plastic and Reconstructive Surgery Journal. But to respond to your question, it depends on the stage. If an AVM is stage 1 or 2, the gold standard still is surgical resection, a radical surgical resection. So if you have the luck to have an AVM which is S1 or S2, meaning it can be radically removed without causing any disfigurement or functional impairment, then surgery is the way to go, definitely. If you have an S3 AVM, then in my hands, the first option now is modified electrosclerotherapy. It helps incredibly. It's somehow revolutionary in the management of S3 AVMs. So as you see, I cannot answer what's the first line because it all depends on the stage of that very AVM.
Well, I think the most significant breakthrough with the MEST, which is your technique, which is modified, is that people who were in a fatal position, where they had exhausted all options, they had no less than 40, 50 procedures. Most of them are under 30 years old, 35 at the oldest. And this is the first time there's been anything that could take the bite out of it, I guess you would say. And you do have some where there's no evidence of disease.
Most where there's no evidence.
Right.
So the thing is, I have been managing more than 300 head and neck AVMs in my career, which I think is one of the most extensive case series in the world. And let me tell you, since I introduced modified electrosclerotherapy, I have been witnessing, and my patients with me, a revolution in the management of AVMs. We are obtaining results that were not even imaginable before MEST was introduced in clinical practice.
That's what we're hearing, and it's exciting.
Yes, it is.
So Nabil says, my capillary malformation, Port Weinstein, is on my hand all the way up to my shoulder. Imaging shows that there are no abnormal clusters, no AVM. and normal blood flow in the deep veins and arteries. However, some superficial veins are slightly enlarged or underdeveloped, and there's mild swelling in the hand. My question is, why can't these abnormal vessels just be manually removed or surgically treated instead of only using a laser? Has it been done before? Are there risks?
Okay. The question is more complex than this. A simple capillary malformation will not produce any overgrowth or asymmetry. It will mostly be a matter of color and the consequences of the skin stain. If you do see if it's evident that there are dilated veins, then that may not be a simple capillary malformation. It may fall under the diagnosis of KTS, especially if those veins are superficial and larger than expected. So my suggestion is to go and find someone who's expert in Klippert-Trenaunay syndrome and ask them for the more appropriate treatment. In general, veins can be managed and removed one by one with either laser or sclerotherapy, or a combination of sclerotherapy and electroporation. But once again, every case is different, so you definitely need to go see an expert in this field and ask the doctor what's the preferable way of managing your condition.
Thank you for that. Again, we are here another 30, 34, 35 minutes. This is your opportunity to ask Dr. Colletti any questions. We have the Super Clinic in October. We still have openings for free laser, free ultrasound. We've been having the clinic here in Milan since 2019.
Yeah, 2020.
2020. And we are going to start rotating. So next year we will be, for everybody who wants to know, the free clinic next year will be in Bucharest. And likely the year after that will be in France, and then the year after that in Spain, and then we're going back to Italy.
Yeah.
So we're spreading the wealth, and VBF is international, so this gives it more international and more access for people in other areas. So Ju Chen wants to know, Z Chen wants to know, how about cryotherapy? Is it recommended?
Well, cryotherapy can be recommended. It depends on the diagnosis. Recently, some expert recommended cryotherapy as the first line of treatment for FAVA, fibroadipose vascular anomaly. In other conditions, it can be used. I would be reluctant to say that it's the first line in most cases, but there are some instances in which cryotherapy is a good solution.
It's not for Port Weinstein.
Not at all.
No, so I'm not sure.
Venous, lymphatic.
Maybe, or pyogenic granuloma, you might treat that, maybe with a little cryotherapy.
Yeah, maybe.
A small pedunculated lesion, something small like a pimple almost.
Or venous malformations.
Or a venous,
yeah.
So that was a great question. Thank you for that. We still can take more questions. I want to make sure I haven't missed any. Or with all of you guys on, you should be asking me all these questions. That question too about why can't these abnormal vessels just be manually removed? Dr. Nasseri is talking about doing this direct stick puncture.
That's what I was saying.
Oh yeah, so
that's sclerotherapy.
Yeah.
Manually, it's a rather vague word in this sense. If by manually you mean surgically, it makes no sense. If you mean manually by manually you mean sclerotherapy, then absolutely this is an option. We do it every day. That works even for smaller veins.
Z Chen said he was asking you the question, that his son has a lymphatic malformation in his right hand. So the doctor suggested cryotherapy. That doesn't sound right to me.
I don't know. I have no experience. Sounds strange to me, but maybe they do have experience. Ask them if they have any scientific evidence of that, if they published about that, if anyone has published about that.
Or
then,
before and after pictures with long-term results.
Yeah.
So, yeah, do your homework. That's what I tell all the parents.
Yeah.
Lisa says, sorry, just another question. For women in menopause, is there anything we can do to prevent further increase in growth and symptoms caused by menopause on the vascular malformation? I've gone gluten-free, which has helped, but is there anything else which would help?
It depends on the malformation. It definitely. Say you have a clitoral trinone, okay? Then in that case you will definitely want a compressive stocking to prevent any further enlargement. Say you have a venous malformation in your tongue, then you may want to sleep with a few pillows more than you're used to, and so on and so forth. So it depends on the malformation and on your specific condition. So you're most welcome to send me details at my email, and we can discuss any hypothetical helping advices.
Thank you for that. Roxana says, my son is 2 and has a complex capillary venous and lymphatic malformation. Well, I was having an online consultation with Dr. Colletti, and after that the secretary came back saying no modified electrosclerotherapy before 3 years of age.
Yeah, I know where we are.
Okay, I also consulted a renowned surgeon who suggested surgery to remove the whole lesion. What's the difference between the modified BES and total resection? What's the chance after surgery to come back?
So, in my opinion, and I'm pretty positive about this, your son is not a candidate for radical resection because the malformation is very extensive, and you cannot just remove such a huge amount of skin and subcu and that's it. You need to reconstruct that. So it doesn't make sense, in my opinion, to do that at the moment, and especially not without any preemptive skin expansion. Modified electrosclerotherapy is totally different because you keep the tissues, you just target the disease, and so it's conceptually and practically different. The thing is, as you have been told, we have been discussing in a multidisciplinary setting your son's condition, and the final word was that we better wait until he's 3.
Saying that our sound is not that great. Well, we are in a lobby, but I think, you know.
Come closer, maybe?
Yeah. Let us know if that's a little better. Would you please make sound up? I don't think we can do that. I don't know. I don't want to press any buttons and have us go off the screen. I think this one is the volume. Okay. Yeah.
But that may not be
I
the
don't know.
volume of
It's
the microphone.
yeah. It's on probably mine. Is that better, Jonas? I don't know.
Just
Okay.
closer to the microphone.
Yeah, so we're doing the best we can. Oh yes, so they're saying it is better. Okay, sorry about that. Good, I'm glad you let us know. So we have a lot more of you on, and Lucas says, is it recommended to wear a brace when it comes to port wine stain and KTS? Best wishes to the dearest doctor from Tonkika?
Oh, yeah.
Tonkika.
Hi.
Luca.
Hi. Well, it is advisable if there's an indication. Absolutely, yes. But KTS is usually a syndrome, a word that is reserved for limb, not always, but in general, limb complex malformations with overgrowth, whereas braces are usually used to correct bony deformities in capillary malformation, not complex capillary venous lymphatic. So, but in any case, you can, yeah.
This is a good question. I read a research from a Dr. Gang Ma who found improvement in port wine stain with photodynamic therapy. Thoughts on this? I spoke to my doctor, and it's not approved in Belgium and Europe, sadly. The risk is too big.
Okay, so first thing first, Yang Ma is a friend of mine.
Oh, that's good.
Yeah, it's the group of Shaoxiling in Shanghai.
Yeah, a good group.
Yes, they're great scientists. I have seen the results they are getting from photodynamic treatment, and it definitely works. Sometimes it does work in cases where PDL was not effective enough. It is not approved in Europe. I don't think it's approved in the US as well. But it does work. I think the only way to have that done on your kid is to ask directly Dr. Lin and his group if you can do it in China, unfortunately. Yeah. But it's not recent. Not at all.
Mm-hmm. So, Jin Chen said his son is 4 years old. So, which one do you recommend? And he's with the LM. Is it better to do cryotherapy now before surgery, or just go straight
I
to
have to
surgery?
see the patient.
Yeah, you have to see
Pictures
the
and
yeah.
imaging.
Okay. Zhu Yang says, how do you suggest to treat port wine stain growth inside the nostril? Not too deep, but the size of PDL device tip is having problem in reaching the spot.
Okay, usually when the nostrils are too, let's say stenotic, so closed, the indication there is surgery. So PDL, if that's the laser your physician is using, will not work to enlarge nostrils. Only surgery can do that.
Yeah, Roxana, who I forgot what her question was, but she just wrote back again saying the surgeon recommended growing some skin by inserting some sort of balloons.
Yeah, expander.
Yeah, tissue. My question was, can it grow back after the tissue expander is done?
It depends. If there's if a radical removal is performed, then it's very unlikely that it will come back. If you leave it at the margins or in depth, then yes, the risk of relapse is existing.
Eunice, I'm trying to find, because with so many questions coming in, we can't remember what every person is saying. So I don't know what type of vascular anomaly you have. You'll have to submit that again if you're asking a question on treatment. I mean, it says, are there any future free clinical treatments? The only free treatments we have are laser.
Yeah.
And you can get ultrasound and dental, but I don't remember what your lesion type is. So, Sophia Sarang, hi Dr. Colletti, I met you in New York. I'm from Miami with KTS and a port wine. My laser treatment is done by Dr. Duarte. I've started taking V-Joyce, a medication she prescribed by my doctor. Said, what do you know about this medication? Well,
V-Joyce is a PIK3CA inhibitor. Name of the drug is alpelisib. It's an inhibitor of a protein which is caused by a mutated gene, and it works especially on the overgrown component of the vascular anomaly. It is in general a safe drug, except for the fact that being the PIK3CA somehow, let's put it simple, related to the receptor for insulin, there is the risk that you will develop diabetes and insulin resistance. So that's the main drawback of that drug. But that's pretty easy to diagnose if that happens.
Oh, I didn't know that.
Yeah.
It's good to know. Okay, anybody, we're caught up with questions. We only have 22 minutes left, so please ask your questions to Dr. Colletti. They can be about AVMs, hemangiomas, port wines, venous, lymphatic. When we had our clinic today, we're always learning new information. Dr. Comey did a study with Boston Children's, and now rather than waiting until
No. We cannot talk about that.
No. This is this is a different study.
Okay.
This is the one that she wants the imaging done because she's asking me to tell the parents by 2 months of age rather than waiting till after 1. Now she wants it by 2 months because Boston said the study she did with Anna Pinto said if it's clear, it's clear. If it's not, it's not. And so they're going. They're that's the new recommendation is to have it at before.
It's the opposite they used to say until yesterday.
Yep. Well, it's the same with the laser. They used to say you can't pre-pool because you'll collapse the vessels. Now they're doing pool, and it's working beautifully. Okay, so are you having an established date for when you will be coming to Romania? Sometime in June is what we're looking at. Probably Saturday or one day, do it in all in one day. Morning would be lectures and the afternoon would be the free clinic. So we can get a lot done in one day.
Yeah.
So we still have some time, so okay. Oh, what surgery in the case of the nostril would stop the growth and stabilize after menopause?
And to enlarge the nostrils, there is several techniques. One is just a removal, a resection, wet resection of the external part of the nostril here, like this, and it will pull the nostril more lateral. Other times, when the nostril is really too significantly too little, then you do an incision in the lower part and put a graft of the ear, from the ear.
From the cartilage?
And skin.
Wow, that's pretty amazing. Okay, so that was a good question. Let me see, what else? So again, we have the free clinic in October. We have been shutting them down because we can only do, Dr. Colletti can do just so many ultrasounds.
Yeah.
And last year, I think we did 57. So that was like, you think about that, you know, an afternoon clinic doing between that and Friday, 57 ultrasounds. And the Sturge-Weber assessments and now glaucoma checkups.
Still, it's something I do gladly because I think it's really crucial to have an ultrasound done by someone who's expert with vascular anomalies, because again, it can change the diagnosis and does the whole treatment course.
Right.
So
and
absolutely.
expectations
Yep.
of what they expect.
Yep.
Roxanne said, one last question. While I visited the surgeon, he had also a multidisciplinary team. The IR doctor for interventional radiology said electrosclerotherapy won't work for Aiden since the lesion is big enough. Will the modified best work for the whole lesion? I don't even know what they're saying.
Well, actually, one of the advantages of electrosclerotherapy, especially modified electrosclerotherapy, is that you can treat a malformation no matter how extensive it is. And that is different from sclerotherapy because sclerotherapy usually dose or size limited. That doesn't apply to electrosclerotherapy. So it's a little surprising what you have been told. I may have got it, maybe I got it wrong. I don't know.
Not. Z Yang said, what do you suggest for thickened and blanched upper lip as a result of PWS? So he's got a
blanched.
Well, we tell them all to blanch it, pressing on it, and that's how we can usually tell if it's a port wine, if it goes white, if it doesn't have anything.
Blanching or blanched I'm not sure I got it right again, because it would be unusual that you have a port wine stain blanched, or you should better specify what you mean by that.
Yeah.
Usually, the thing with lip in port wine stains is hypertrophy, and it depends on your age. If it's a kid that is showing signs of ongoing hypertrophy, then I usually do inject a little bleomycin to stop the process. Otherwise, if you're an adult, then you're a candidate for surgery. Surgery can produce very good results in experienced hands.
Thank you for that. Alicia Marie, your
Hi.
patient from Florida. She said, she said, hello doctor, it's Alicia. I'm doing fine, except that my ear now looks like something, a real strawberry. I guess that's what she's saying, a strawberry, like a real one.
Yeah. Yeah, send me pictures, Alicia.
Yeah. I've never heard of that, but who knows, right? Anything could be possible. Okay, so is there any other new developments for infantile hemangiomas? Anything new?
Yes. They're trying to see if the addition of propranolol and statins can produce any additional
Clearance?
yes.
Ooh, I like that.
There's a biological reason why this should work, and the reason is that propranolol acts by inhibiting a protein that is called FOX, and that in turn inhibits the production, the activity of another protein that is directly inhibited by statins. So using a combination of the two should have even a more powerful effect on infantile hemangioma.
Thank you for that. Nabil said, I was misdiagnosed with KTS several times at different hospitals, even though I had 2 MRIs and an echo. After a biopsy, Dr. Laurence Boone in Brussels, and an echo, I was confirmed to be just a capillary malformation.
Yep.
What causes some doctors to misdiagnose these? Well, they're not taught about it in medical school.
No, the thing is, yes, we're not taught at medical school nor at our residencies. But the thing is, many doctors will think that when they see a capillary malformation of the entire limb, then that's by definition a KTS, but that's not the case. KTS is a syndrome, and the word comes from the Greek syndromos, which means running together, walking together. So a syndrome is a combination of symptoms and signs, and in case of KTS, it's not just a capillary malformation, it's a capillary venous, frequently lymphatic malformation with overgrowth. And if you don't have the venous component, it's very, very unlikely that that is a KTS. But most people don't know that.
It's always good. I always learn something new from you so I can help patients. We've had a lot of really great questions. We still have 14 minutes left with Dr. Colletti, so please ask your questions. You will be in the U.S. in October. Do you have any other big trips coming up where you could see patients?
I do have big trips, but I don't think I will be authorized to see patients.
Okay. Oh yeah, with everything going on now.
Yeah.
We even had patients come today that are from Iran, and they were like, we can't come to your conference now. We can't even get a letter from you to let us come. So yeah, that's not good. Let's see. Okay, that was the nostril one. All right, guys. Hi, Marla. I see you just joined us. Athens, Warham, Zhang Yang, Doris Ortiz. Send me your questions. Dr. Colletti's got 13 minutes left. Let's not waste it. Let's ask him those tough questions.
Don't be shy.
Don't
I
be
encourage
shy.
you.
Yes. I'm just trying to think of like some of the repeat questions that I get are, why do some doctors laser and then get scars, and why do others laser and they don't get scars?
Well, the answer may be pretty articulated, but to simplify it, I would say it probably depends on type of laser that's being used, because one thing is a PDL, a totally different story is an MDAG and a 532, meaning the KTP and CO2, and we have very different lasers, and PDL is the safest one. Even then, you have to be very precise with the delivery of energy, meaning settings. And if you go too high, if you do double, triple pass, then you can cause a burn, and the burn in turn can cause a scar.
That's good info. Bill, well, I did try to come to Europe. I tried to come to London. I had 100 patients, but the NHS would not let us come, because not only are our doctors not licensed in the UK, they're not licensed to treat babies. And because they don't even typically start until age 3, so there was just too many obstacles. Next year we'll be in Bucharest, and then Paris, and then Spain, and then back here. So hopefully one of those will be closer for you. Mary said, I would like to say hello to my doctor, an angel for me, and my AVM. That's Mary Simone.
Oh, ciao.
Mary Simone.
Ciao, Mary. I am very, I care so much about her. It's unbelievable, because the first time I met her, it was probably some 20 years ago, and I told her there's nothing I can really do for you, because she has this AVM, and I hope I can tell Linda this. She has this AVM on the mid of her cheek, and it's a pretty huge one. And so at the time where I did not have developed the mesh technique, I told her it's better if you do nothing, leave it alone. But then we did a single session of mesh, and I think we got 80% of the AVM off with just one treatment. Correct me if I'm wrong, Mary.
Wow, that's amazing. And no bleeding, right?
No zero.
That's just amazing. These, we call them what? Arteriovenous
Monsters.
Monsters. Because you don't want to get diagnosed with an AVM. But if you do, Dr. Colletti can help you. That's the good thing about having doctors like you, top experts in the field, as part of our
research is the
team.
key.
And
Research is the key.
Yep.
Experience and research.
Yep. Okay, so why does my once smooth birthmark start pushing out little bubbles and bumps, giving it a very uneven surface?
That's most likely a port wine stain. If that's the case, then what you are experiencing is called cobblestoning, and it's pretty typical for untreated port wine stains. You should seek medical attention and help, receiving help for that. It's manageable.
She said the birthmark covers the right side of my face and my cheek. I'm not sure. What does my one smooth birthmark start pushing out? Okay, so the answer the answer is still the same. Oh, she said you were correct. Mary said you were correct. Whatever you said, whatever that number was, she said you were correct. I see somebody's from Russia. Hello, hello, hello. I can't say your name, can't read it, but I see you. So I just want you to know that. It looks Russian to me. Could be Ukrainian, I don't know. Okay, birthmark covers the right side. Okay. Seeing some repeats here. Did you answer the question about after menopause, does a port wine stain still grow and thicken?
Yeah.
It does?
I did.
Because they're just progressive.
Yes.
Okay. Except for a small.
Usually at a very much slower pace, but they will grow lifelong and large, I should say, not grow, lifelong.
Yes, Nabil, we know Dr. Boone, and we are working with the groups that will allow our doctors, our top doctors in the world, to come to the country, and there aren't many that are open to this. So he's saying Dr. Boone in Brussels is a specialist in vascular malformations.
She's a friend of mine.
It
so
could
you know.
be a great place for an event, but I don't think they have a VBF free clinic there.
I don't know.
I think it would be supported. So we're dealing with also meeting doctors with private practices, because by having a private practice, you don't have to go through the red tape, which can be so discouraging.
Paradoxically, makes things much easier.
Yeah. Rhett said thank you. It's very expensive here in South Africa. I will just have to live with it. Yes, it is a port wine state. So it's very expensive. I don't know who you see in South Africa, but there is someone on our website at birthmark.org, and you might want to at least just look at it.
Absolutely.
Because I have had a number of patients say they go there. So, well, we're coming down in 6 minutes. It has been a busy, crazy day.
Oh, yeah.
Right?
Lovely busy day.
Yep. Yes, we keep fighting for you, Nabil. I've tried desperately. I had 100 patients, all with airline tickets, ready to go to the UK, and we had the plug pulled on us at the last minute. But serendipitously, the strangest thing occurred on the day of the clinic was the fire in Heathrow, and none of our doctors could have landed, and the lasers couldn't have got there. So it's like God had our back. But
it was simply not supposed to happen.
no, it wasn't supposed to happen, but that doesn't mean I'm going to stop fighting for early intervention, appropriate diagnosis. We get blocked. We get told crazy things like stop doing what you're doing, but I know in my heart I'm doing the right thing.
You are.
I always have the baby or the patient's interest at heart. I think of them as my own child, adult or child, whatever their age is. I take care of them as if they were my own, getting the best, most accurate information. And a lot of you have talked to me, have emailed me and said, who should I go to? And you can back that up. So, are there any little pearls of wisdom you'd like to pass on? I mean, we have a couple more minutes, but...
Well, you know, my most extensive field of research is AVM, and I really suggest anyone who has an AVM to try and find a very expert physician, because most of the rest of his or her life will depend on how he or she will be approached the first time. So it is very crucial. Ask your doctor who's following you how many patients have been managed. Ask for before and after pictures. Try and find using PubMed how many papers he or she has published on the matter. So try and just be sure that you're seeing the right doctor.
And we have a lot of FAQ booklets on our website. You did a couple of them with me. We manage the 9 primary birthmark types, vascular, birthmarks, anomalies, and related syndromes that comprise of about 98% of all of these. There are some real outliers that make Thurner and Parks-Weber and Maffucci syndrome, Cowden syndrome, but these are the ones that we focus on, because the other ones I might get one question a year.
Yeah.
But the most common questions that come in are either the port wine stain or the hemangioma. You and I, when we met, it was because you were doing a presentation on AVMs, and AVMs, I call them arteriovenous monsters, yes, because they're beasts. They're hypervascular. The wrong treatment can be life-threatening. It can be life-threatening.
No doubt.
And every time it's like that expression in the Marvel Cinematic Universe, cut off one head and 3 more grow. For a Hydra, they say that in the Marvel Cinematic Universe. And that's what happens if you do the improper treatment of an AVM. you cut off the head and 3 more come back, and it comes back with a vengeance.
Yeah, same applies for complex venous or lymphatic or capillary malformations of the face and the oral cavity. Don't take no for an answer when you ask the doctor, can my overgrown tongue be corrected surgically? Can I have jawbone surgery to correct my bite? Everything or most of the conditions related to the presence of a vascular anomaly can be corrected or ameliorated, a big deal.
Right. And you know, I just realized, because we're in Italy and it's in the morning,
Yeah.
in New York it's only 11 o'clock in the morning, and in California it's only 8. So that's why everybody on here is like from Europe or other countries. There's almost nobody from the US, but when you're in the US, then it's like most of them are in the US.
Yeah.
It's been a very exciting session. I'm really always happy to hear more progress with the AVMs, which you're starting to see. And trust me when I say this to people, these aren't for the faint of heart. But you are passionate about them, and you've got it right, like that. I'm gonna find this.
There's a saying that I love, and it is, AVMs are not for the faint-hearted nor the arrogant.
Oh, that's a good saying. On that note, we will see you next month. We haven't announced yet who our Facebook Live will be next month. It's going to be one of 2 experts, but we will publish it in the next week or so. Thank you all for joining us. Thank you for your valuable time.
Thank you.
It's been
Thank
a
you,
long
Linda.
day. And we
This
will...
is all happening because of you.
Thank you, and we will see you all back with Dr. Colletti next year, if not December of this year. So thank you all. Stay safe and stay well.